Clinical examination of the musculoskeletal system, the ankle joint and the foot. The ankle joint is a synovial joint, properly called the tibiolateral joint, although the fibula also takes part of it. It is usually described as being of the hinge variety, but these movements are not quite those of a simple hinge. For the axis of rotation is not fixed, but changes between the extremes of the plantar flexion and dorsiflexion do occur. The articular surfaces are covered with hyaline cartilage. The weight-bearing surfaces are the upper facet of the latiss and the inferior facet of the tibia. Stabilizing surfaces are those of the medial and lateral malleoli, which grip the sides of the latiss. The joint is enclosed in a capsule lined with synovial membrane. Symptoms from the ankle joint are pain and swelling, usually from trauma, and the pain at the ankle is mostly from sprain caused by torsion of the ligaments holding the ankle joint. The ankle joint and the foot are examined both in the lying and standing position. Both limbs should be fully exposed to allow comparison. So observe the nails and the skin for cutaneous lesions like psoriasis or vasculitis, and examine the soles for the rash of keratoderma plenorrhagica, and examine the chin for erythema nodosum, and also examine the muscles for wasting and the knee and hip joints for degenerative inflammatory arthritis. Observe for evidence of deformity and swelling. Observe the foot for varus and valgus deformity, previous trauma, and degenerative or chronic inflammatory arthritis. Look for equinox deformity, foot held on midfoot in plantar flexion, and so pes planus deformity or flat foot deformity due to collapse of the longitudinal arch. And observe for pes cavus also, and also calcaneus. Examine the forefoot for hallux valgus, which is common in normal people due to wearing of non-fitting shoes. As observed for hallux varus, and observe for broadening of forefoot in rheumatoid arthritis due to dorsal subluxation of toes at the metatarsophalangeal joints, with increased flexion of interphalangeal joints associated with underlying callocytis. Observe for swelling, the symmetry and distribution of the swelling, which give a clue as to the exact type of arthritis. Symmetrical swelling is seen in rheumatoid arthritis, and asymmetrical swelling in one ankle or foot is seen in seronegative arthritis. The swelling of all the three joints in one digit, giving a sausage-like appearance, is seen in psoriatic arthritis. Isolated swelling of the first metatarsophalangeal joint is seen in osteoarthritis. Observe the soft tissues, Achilles tendon, and dorsum of the foot for swelling bursitis. Observe the underneath of the metatarsal's head for adventitious bursitis, which may produce swelling. Palpate the knee and foot to confirm active inflammation and classify the cause of the swelling observed. Using the midway between the knee and the ankles as a reference point, you palpate and compare the temperature with that overlying ankle, the mid foot, also small joints of the toes. Gently squeeze the ankle joint mid-tarsal and interphalangeal for tenderness. Warmth and tenderness signify active inflammation and synovitis. By manually palpate the interphalangeal joints to determine the type of lesion causing swelling. Firm rubbery swelling suggests synovial thickening. Fluctuancy suggests effusion. Bony swelling suggests osteophytes or degenerative arthritis. Observe the separation of the toes in early synovitis, the so-called daylight sign, and is unusual in adults. Now palpate the soft tissues. Palpate the Achilles tendon for swelling and tenderness. So note any nodularity or isolated hard painless nodules as in rheumatoid arthritis, and palpate the site of insertion of Achilles tendon on the posterior aspect of os calcaneus for Achilles enthesopathy. This is very painful. So you note any pre-Achilles bursitis and examine the inferior part of the heel for enthesopathy. Firm deep palpation will lead to pain, or one may discover a rheumatoid nodule. Palpate the tendon sheets for effusion, synovitis, or rheumatoid nodules on the extensor tendons. An isolated cause of pain in foot is compression of metatarsal heads, and this produces localized pain in second and third and fourth metatarsal heads. Small bursa between metatarsal heads and interdigital neuroma can also produce pain. Tests for range of movements. First, you test for active range of movements to determine the comfortable range of movements of the patient. Dorsiflexion and plantar flexion of the foot. You test for inversion and eversion of the foot, and then test for passive assessment of the range of movements. Palpate for crepitus, which is evidence of the presence of osteoarthritis. You test for eversion and inversion of the foot by fixing the talus by holding the medial and lateral malleolus, and then grabbing the pes calcaneus. You evert and invert the foot. So move the calcaneus medially and laterally while fixing the lower end of the leg. It has movements at mid-tarsal joints by fixing the hind foot and also by gripping the calcaneus. You then grip the foot and test for inversion and eversion of the mid-tarsal joints. It tests for range of movements of interphalangeal joints. And lastly, you perform a neurological examination, testing for sensation proximal and distally. You establish mononeuritis multiplex, as in rheumatoid arthritis, and it tests for compression neuropathy in tarsal tunnel syndrome by compression on the posterior tibial nerve, which leads to shooting pain in the foot. Finally, you get a patient to stand, bear weight and walk, and look for pes planus, valgus, or deformity, which is more obvious when the patient is weight bearing. And as he is walking, you observe the gait and look for loss of mobility at ankle joint and first metatarsal phalangeal joint, which leads to stiff gait walk.